I'd like to talk about what I think the comprehensive geriatric assessment brings to the integrated independence team and what the integrated independence team brings to it. Currently, we have lots of ways of working in hospital, outside hospital, and where we fit is between the two. It's managing people from hospital to home or preventing them going into hospital from home. And that process often, if we look at a typical patient coming in to the integrated team, will involve someone who's been running along fairly steady, and then suddenly they'll take a deterioration in what they're able to do. A lot of that can involve health needs, so they end up being in hospital. They've changed because they've had a serious infection, a serious illness which has been partially treated. And then they go out, and the aim of the team and the focus of the team is often about getting them back to the level of function they were at before they had this precipitous illness. Often what we see is that the person is very focused on getting back to living and working and being the way they like being. And that becomes very much focused on a therapy rehabilitative process with independence assistance helping people while they just initially can't manage those essential functions independently. What I'd like to bring into the mix is what nursing and geriatricians add to that process. And that involves recognising so much about their health needs. Often people come in and they've got long-term conditions, common ones being diabetes, high blood pressure, previous stroke, previous heart attacks. And what happens is they take a little knock because they've been unwell, their heart failure is worse, they've had a small mini stroke or a small stroke. And hence we become very, very focused on what their capabilities are. What the geriatrician adds to the mix is that we can recognise all of those primary factors that contribute to the risks of another stroke or a further heart attack or worsening heart failure, and we can manage them. Equally, the nurses bring into the mix a gamut of knowledge about how people manage their medication, their behaviour around managing their long-term conditions, which again compounds how those health needs are managed, which impacts on their rehabilitation process. So the comprehensive geriatric assessment is bringing the skills of the whole team together around the patient. And the key elements of the comprehensive geriatric assessment is incorporating the health needs, the social care needs, the therapy needs, and often the psychology and mood that impacts on all of them and the ability of the patient to engage with that process. There are often triggers outside reflecting on a person's health up until the point of presentation that help the team identify when we should be triggering a comprehensive geriatric assessment. The first is at the point of entry. If people have got multiple comorbidities, so long-term conditions or progressive conditions, dementia being a commoner problem, which is getting much more prevalent in the older population. And if people have dementia with any other long-term condition, if they haven't had a health needs assessment with a geriatrician and a nurse, in addition to a therapist, a social worker, putting in input, then they won't have had all the needs around them met. And that's the purpose of the CGA, is to get all those professional perspectives around the person saying, this is an important impact on that individual, that's another environmental important issue, this is a social or a family dynamic issue that will all impact on what that person's capable of and capable of recovering from in the future. You've got to ask yourself the question, is there a reason that they're not making progress? We're very, very good as a team at saying it's mood, it's motivation, it's disengagement. They're very private. instead of saying, well, part and parcel of that is identifying some of those added needs, usually health, but often cognitive as well as mood related, that are impacting on how they respond to goals. Let's give an example of a person who is referred, and a common referral process will be they've had a series of falls at home and they've been referred in for an environmental assessment and a mobility assessment and a social care assessment because they've not been managing well, and the presumption is these falls are mechanical. When you go in, the first therapist finds that there are tablets everywhere, the environment's in pretty much disarray, there's very little food in the kitchen, and there's lots and lots of clutter. Just again, to look at the core components of the comprehensive geriatric assessment, we look at what the person's nutrition is like. That isn't just swallowing, it's their mouth, their teeth. In addition to the physiotherapist who looks at mobility and looks at how they manage with and without aids in their balance, we look at the neuromuscular contributions to why their mobility is deteriorated in terms of their skin, which is very much wrapped up with their mobility and nutrition. We'll look at their skin, see where there are problems, where there might be, insidious disease. We will manage that to prevent disease in the future. In terms of falls and the other geriatric giants, which are confusion, delirium, continence, again, there are often underlying health needs that are unidentified and unmanaged, which we will look at together with our nursing college to manage better, which means more people are more equipped to manage rehabilitation. They're more likely to have the confidence to regain normal function. If we look at most of the ADLs that the OTs and therapists look at, often we can look at sensory impairment, which often gets lost amongst it, as well as planning, executive skills in cognition terms, which again impacts on how people manage their activities of daily living. And we will signpost and agree with our OT and therapy colleagues the best way to help people manage sequencing and planning when they've lost some of those skills through cognitive impairment. Finally, as a group, all of us have a responsibility to contribute to understanding how mood, cognitive impairment impact on behaviour and communication. So I think it's really important that we're all delivering together the most efficient care around the person, whether they're referred for rapid response in the community or whether they're part of the home treatment team. And when they take a step down, we have the capability in our team to ensure that we can treat any intercurrent illness, particularly delirium, very quickly. And if we can do that, often we have the capability of saying anyone who's taken a step down during their course of intervention or at the point of presentation, we should be able to treat them as part of our 6-week intervention in order to get them back to their baseline most efficiently.